So with that, camera has launched. The meeting is being recorded prompt. So we accept that. I wanted to take a moment for us to just kind of have a reflection. For me, it's been a big week of reflection. I just turned 50 yesterday. And with that, there's just a lot to think about, right? I mean, I could have lived half of my life already and then maybe have a whole nother half. And just thinking about my experiences and kind of what has brought me to this place and what has brought me to this work and being thankful for the things that I have experienced. So I'm wondering if you all would join me in an opportunity to reflect on your own personal experience, whether that is in the last week, in the last month, in the last year, or maybe in your lifetime. It could be about something personal, it could be about something professional, however it is that you'd like to reflect. And I'm wondering if you can think about that from a perspective of gratitude and thanks and what has brought us to this work. May is Children's Mental Health Acceptance Month. And I know for me, just having the opportunity to work in children's mental health and do the work that I do every day, I couldn't have done it without my experiences with my own child. And so I'm just so thankful for that and this experience. So however you'd like to reflect, whether that is in writing, whether it's just thinking. So feel free to shut your camera off if you'd like. Feel free to close your eyes, whatever works for you. I'm going to go on mute for a minute and I'm going to close my eyes and just think and reflect for a minute. So take that time and then we will rejoin one another in just a couple of minutes. I'm going to bring us back to center. If everybody would join me in taking 2 deep breaths. Breathe in deep. Hold at the top. And then blow them out. And again. Awesome. I hope you all were able to express some gratitude for yourself and your experiences and move through the end of this work week in a positive way. Thank you for all the work that you're doing, and I just appreciate you being here. All right, so with that, I wanted to share a little bit about our agenda today. So we're going to have Hillary Harrison leading us in community engagement around our roadmap, and so we'll have some conversations and breakout rooms to have those discussions. And then after that, we will be taking a break for about 15 minutes. And then we have University of Connecticut folks coming to talk about our Medicaid analysis report. So again, I welcome you. And I think if there are no other big announcements, we can move forward. Tam, do you have any other announcements or things you'd like to share?
I just wanted to point out that we still have a few child family behavioral health staff members that haven't done their introductions, presentations. So we'll finish those up next month and take a break on that for this month.
Perfect. And then Hillary, I see your hand up. I also wanted to share that in honor of Children's Mental Health Acceptance Month and Week, next month we will be doing an activity related to children's mental health acceptance. Hillary?
I just wanted to say that we have had a fellow who's been doing a lot of youth engagement work. And so she is going to be reporting out on May the 1st, and that's in our newsletter. And so you are all invited to come hear her talk about those results on May the 1st. And I will make sure I drop that information into the chat in just a minute. But She's talked to around about 200 young people across Oregon, in all different settings, from rural down in Coos Bay, some Eastern Oregon folks. She's been up in the Portland area. So she's got a really good spread of young people she's been talking with. And so, you know, we'd really invite you to come and hear their feedback on Wednesday, I guess that is. So we'll look forward to seeing some of you then. Thank you.
Thanks, Hillary. I'm excited to hear about the work that she's been doing. And how is it already about to be May? So hard to believe. All right. Well, Hillary, are you ready to get started and sharing? We're a little early.
I can do that as soon as I've organized all my screens here, because
Okay.
obviously a day when I've got too many things open. So thank you. So one of the things that is going on right now is that we are taking our next look at a strategy for the for children's behavioral health in Oregon Health Authority. So we had a lot of work was done in 2020, 2021, 22, and that culminated in us issuing our roadmap in middle of last year. So we've been working hard on that. And as part of that process, we want to center both the voices of youth and families, but also clearly our community and providers. And so as part of that, we would love to do the same kind of engagement with you that we have been doing with others in the community. So again, the questions we're going to be asking you today are also the same questions that, as I said, our fellow has been taking out into her work in the community. So using that same format to just get some opinions and have a conversation with you all. So the questions essentially are, when you think about mental health and substance use treatment and supports, the first question is the open-ended one around what's been most helpful to you. The second one's going to be what wasn't helpful, and what could organizations you look to for support have done better. And then the final question is actually the one that I hope people spend the longest amount of time on. And that one is, if you're the one in charge of fixing the system, so it's your chance to have the magic wand, or your opportunity to have that real feedback. So if you're the one in charge of fixing the system, what are the two things that you would do first? So that really is a request to help us with what are the priorities that you see from your perspective around what we, the Child and Family Behavioral Health team and even OHA should be doing around children's behavioral health in Oregon. So that's the format of what we're asking for. And I thought that the best way for us to do that is probably to break up into some breakout rooms to have that conversation, to give you some space to do that. And what I've also done is to set up a Jamboard, so that you can either put your feedback onto the sheet, or you can do it through conversation. And I really hope that if in your rooms, that if you're not putting on things yourself, that one person in the room would make sure that all the thoughts that come from your group get added to that Jamboard. So I will add the Jamboard link if someone hasn't already from the team. But I see that Tamara has very kindly put the questions into the chat, as well as they'll be there on the Jamboard to help guide you through that. So I will just share my screen and show you Jamboards, because I don't want to make an assumption that you've all done that before. But if you follow the link in the chat, let me share my screen. I will just give you a quick how-to for Jamboards. So well, maybe you can't. Can you see my Jamboard? Okay, it's not outlined in red today, just to not help me know that I'm sharing. But so this is what you'll see when you enter a Jamboard. This is the first page. And so it has the question at the top of the page, and then up here at the very top where my cursor is, you can see that there are a number of different pages. And so you can move left and right onto those. You can always go back to something you've seen before. So those pages are there, and they have the questions from the chat ready for you to go. For input, over on the left-hand side, you have a toolbar, and that toolbar has pens, so you can write. It has an eraser for when you get things wrong or decide you'd like to change something. It has an arrow, but the most important one is the square in the middle that looks like a post-it note, and it really is a post-it note. So if I click on it, it opens up a sticky note. You can change its color, and then you can put whatever your comment is. So what was most helpful to you? Having a therapist who spoke Spanish. We'll have as an example, you hit save and it magically appears on the board. And so when it's on the board, it can be tugged to a different place, but they all tend to get lumped somewhere up here. And so that's how you contribute to a board. And so that's the essence of it. We'll get you to drop things onto the board. There's normally a little bit of moving around with a big group, so I'd suggest not echoing others at the moment. When we get a little bit further on, then maybe marking them up with a star or whatever, we'll do that. But for now, we might be tugging them around, and when you put drawings onto it, those don't move with the post-it note. So, and you can do the same on any of the 3 pages and just leave your comments. It's anonymous. You can see at the top here, everybody gets to be an animal, and who knows which is which animal. So does anyone have any questions about how you use a Jamboard before we go into breakout rooms?
Hillary, I just wanted to clarify. So if somebody has a theme already on the board, we could still put that theme on there, but we wouldn't want to do any markups or coloring on it, so we could still note it.
Yeah.
Okay, great.
You might put yes, Spanish, but you could definitely just write your own thing to repeat that.
Okay.
And we will give everybody at the end a quick opportunity to look at that, and then that might be a good point when you know, put a check mark or a star on something you like. But let's wait until we've got most of the input in before we echo, if that makes sense.
Right.
So I asked Tamara to set us up in rooms of 5 or so. So did I give you enough time to do that, Tamara?
Yes, I believe I have the rooms set up.
And being trauma informed, I want to say, if you don't want to go to a breakout room, please stay with us. If you're on the phone, you can't go to a breakout room. And so we here can then take your input and put it onto the pages. So we can do that verbally in this room. And so please feel free to stay, or if you're in a breakout room, you are welcome also to come back to the main group if you've got questions or whatever. Tamara, how long do we have for this? So how long am I telling people that they're going to be having opportunity for that conversation?
But we have you on the agenda, Hillary, until 11. And so I'm not sure how long we want to do breakout rooms and how long we want to have the conversation.
Okay, so Tamara, I would love to do, I think, 15 minutes doing what was helpful and what was not so helpful, the first 2, and then we'll come back very briefly and then go back into the breakout rooms to do the priorities, so that we just sort of draw a separation to help us change our brains to, okay, now what's the most important things for us to be thinking about. So does that work for you, Tamara?
Yes, we'll do 15 minutes and come back. Yes.
So 15 minutes for pages 1 and 2, and questions 1 and 2, and then we will rejoin. Okay, well, with that, we will whisk you away to random groups. Well, thank you all, and thank you for coming back. I can see that we have everybody back from the breakout rooms. So, and we had a lot of things added to the wall. Is there anything somebody really is passionate about sharing of what you talked about in your room?
I'll just share, we had a really robust discussion about kind of non-traditional supports and holistic supports, and how it would be wonderful if they could be funded through insurance benefits so that people didn't have to stick to traditional models. And so we noted some of those specifics like yoga or gym memberships or acupuncture and those sorts of things.
Great, thank you. I saw Roberta had her hand up. Roberta, what were you wanting to add?
So I think that, the state's doing great things in setting up the 988 program statewide. And I think that more and better outreach would be fantastic to police departments across the state and to school districts, because children who are melting down and blowing out while at school or while on transportation, the school districts still call 911. And that's completely unhelpful. But if they knew about 988, perhaps they could help the youth instead of penalize the youth. So,
Right.
yeah, so.
Thank you. So I can see a number of themes around education and emotional literacy. We have some themes around, there are a number of things here that refer to schools, and we do have someone from ODE with us today. So I'm sure she's taking note of some of these conversations, and we will make sure that we also pass this back to her as some of the priorities that were coming out today, because there are clearly some themes that are very applicable for them to be noodling on. And for us, I think there are some ones around bridging the gap from inpatient and stepping down. I can see some things around consistent policies and procedures, hospital to hospital, around the handling of crises. There is certainly something around respite, which I know is already something that's on our mind and our things that we are dearly hoping we can work to sort out. More providers who are able to help with IDD, so that's intellectual and developmental disabilities, some access issues and funding for the non-traditional things. I think that's what Christiana said. So this is a really great list of things for us to be thinking about in terms of as we set our priorities for the work that we want to be doing in the next 4 years or so as we write our strategic plan. And I know Chelsea is on the call. I don't know whether, Chelsea, you want to say anything at this stage, or whether you are happy that we move over to break. First of all, I'll ask Carol. Carol, you've got your hand up. What would you like to say?
Yeah, I just wanted to call out coaching from certified coaches as an alternative that can be provided for some of these needs.
So you
So that the coaches can be reimbursed for providing support, just like the other mental health professionals. Because it's an alternative system of delivery of care.
Okay.
And when I say coaches, I mean life coaches.
Okay, I have added that there. I don't know that I spelt it completely correctly, but I wanted to capture that quickly. Thank you. Kirk, you had a comment?
I did. And we didn't know how to do the points that you've got on the bulletin board there. So I would say a need for greater expertise. I think I think if you look at the data from Mental Health America that compare different states, the needs of Oregon teens are actually greater than most other states. But when most people think Oregon teens, they think it's like teens of across the country. But the needs are actually greater in Oregon. And I think what I come across is youth that are not getting better. And it's not until they get appropriate expertise that they realize their child may very well have autism and anxiety and impulse control problems, as one example, or what may be labeled as an adjustment disorder is actually pretty severe depression. And so I think part of it is access to greater expertise, and then really helping families know what to do when their child is not getting better, what steps they can take. And I would say both of those are pretty important.
I would like to just add to that. We with some data that for those of you who know the EASY program through OHA, the Expedited Assessment Services for Youth, where right now it's currently in Multnomah County and I think Deschutes County, with the hope of it being expanded. So there's been like 45 kids that we've seen in all kinds of different like risk situations in juvenile detention and temporary lodging, getting ready to be removed out of this home and school, looking to get in, like trying to get into residential, and the vast majority of them, like 30 something of them, have developmental conditions, whether that's autism or an intellectual disability that has never been found or even like considered, like specific learning challenges. ADHD seems to be the only one that people target and like identify early on. But I mean, like we're talking about a 15-year-old coming in from detention to do an assessment or doing assessment there and being like, he has an IQ of 62. Like just these gross, gross oversight when it comes to considering neurodivergency and developmental delays, and just people not having the expertise to screen for that, and or the confidence or kind of desire to be looking into that, kind of saying, oh, that's not my specialty, or that's not something I know about.
Thank you, Roxy. Yeah, I think that it's exactly why we need programs like EASY to help with that. And thank you, Kirk, for your comment. Chelsea, did you want to add anything before we go to break?
Oh, just a huge amount of gratitude. I mean, this is everything I'm hearing you all say, and what we've seen on the Jam board is right on what we're hearing across the state. And I think what's really helpful about doing this exercise of a recheck-in on initiatives and efforts is that we want to make sure we're still going in the right direction. So just really appreciate this group and the participation and continued support of this roadmap as we continue to move forward. But thank you. And thank you, Hillary, for facilitating. You do such a good job.
Thank you. And so we're going to go to break now, and then I think that the University of Connecticut then joins us immediately after the break. Is that right?
That is correct.
So just to tee that up, they have done a Medicaid review looking at how that works across Oregon. And so they're going to share their results with CSAC after the break. So back to you, Tamara, for any break instructions or...
Not at all. Just enjoy your break and be back at 11:15. Thank you.
Thanks, everybody. We'll see you soon. Welcome back, everybody. I hope you enjoyed your break and you got your wiggles, or you got your coffee or your water refreshed and are ready for our second part of CSAC, I also just want to kind of echo what Chelsea had said, and thank you all for doing the activity. This is exactly why we have CSAC. This is an opportunity for us to be able to share the things that we think are most important in regard to children's mental health work. So thank you so much for sharing that. And I agree that we didn't have enough time, and I would love to see this maybe as a quarterly activity or something we can come back to, and maybe even have longer conversations within breakout rooms in order to further explore. And so with that, I am going to turn it over to Hillary in order to introduce our Yukon folks who are here today. Hillary, take it away.
Okay, thank you very much. I believe that did we get the Yukon folks? I know they were joining, but now I can't see. I can see Johanna.
Hey, Hillary. This
Hey.
is Johanna. I think we're still waiting for Deborah on our side, but Suzanne and I are here.
And she just popped into the waiting room, so we will wait for her to pop into the real room. So there we go. I think she joined us. So thank you all for being here today. And the University of Connecticut houses a center of excellence for things like wraparound and for system of care work. And so when we started thinking about financing and how to run a children's system, we believed as Oregon that what we needed to do was to take a pause, to take a look at what we were doing, and to really look at Medicaid. And Medicaid is the money that is the funding for Oregon Health Plan. So some of it comes from the federal government, some of it is matched out of the state. But you know, things evolve over time, the way rules are written and the way money flows. And so we have a pretty historical system of things that have been bolted together over time. And so as part of doing strategic work for Oregon, what we wanted to do was to take a good look at what we were doing and what we weren't doing. And so we decided to contract with national experts to give us that outside opinion of what we were doing well, what we're struggling with, and what we could and should be doing next. So these folks are from the University of Connecticut today, and I'll let them do their own introduction in just a second. But they really did spend a lot of time reading a lot of documents that are really, really boring, just saying. But I'm sure they found fascinating. And they have brought their expertise of what they see other states do and what they believe is best practice to really look at all these things that are to do with Oregon and to give us some guidance around next steps around how we could and should be funding things, some things that are recommendations. And so I'm going to hand the session over now, I presume, to Deborah, who's going to talk us through the work that they did, but can't say enough about how much time and detail they put into doing this and how helpful it's already been to conversations that happen internally within OHA and also externally around what to do next for systems and so on. So with that, over to you.
Great, thank you so much. It's good to see all of you. I am not sure if any of you have been part of our presentations about this financing analysis. If you have, then this is a bit of a repeat. But we really just want to take the opportunity to share with you what we found, what we did really, what we found, and hopefully it can be a useful document to you. So I am Deborah Harberger. I am an assistant extension professor at the UConn School of Social Work, and I'm director of our policy and financing team at Innovations. And I am joined by my colleagues, Lena Billick and Johanna Bergen, also at Innovations Institute, and Suzanne Fields, who is a national expert and consultant and works very closely with us. And so Suzanne and Lena and I did the work of this report, and Johanna has been involved in related work. And so we wanted to make sure that we're all hearing the same things and sharing the same things, because it's no good when right and left hand don't know what each other's saying. So with that, I will go ahead and share my screen, and share the presentation. And then if there's questions, stop me. It really kind of goes through, aligns with the document itself. So let me just, okay. All right, hopefully you are seeing that in full screen. Okay.
Yes.
All right. I'm just making sure that moved forward because I did something strange with my settings, and I always regret that. Okay. So the purpose of this financing review was to review the existing structures related to children's behavioral health and Medicaid in particular, to help inform the system of care in Oregon for children, youth, and families. And so thinking about what maybe is missing from the authorities that you're already leveraging from the Centers for Medicare Medicaid Services, CMS. Where are there transitions that are going well and not so well between the different authorities and the different structures, settings, really grounding and centering equity and your goals related to equity, and how can maybe some of these authorities help get you closer, some of the practices. Are there things that we need to look at with your waiver language, and then really looking at your coordinated care organizations, your CCOs, and looking at areas for opportunity, alignment, strengthening practice. So what we did was we looked at over 70 documents and websites. And it really was a point in time document review. And so I just want to really emphasize that. Most of this took place over the fall. We did go to a handful of updated documents in January, but we know that the work keeps happening. And so there may be things that we present today that you say, wait a minute, I thought that's already changed, or we're fixing that right now. And that's great. It's a dynamic system, and it's up against a point in time report. So we also only spoke to 10 individuals for key informant interviews, because the purpose of those interviews was to answer questions we had about the documents or to point us to additional documents. We did not do a deep dive into county level, regional level, local documents. We did not explore every single individual contract. We looked at the contract templates and some of the components across, but really this was a look at the state level around the kids' behavioral health Medicaid system, and really a desk review, a document review. We grounded what we did, what we always do, in systems of care. And I know that this group in particular is probably well versed in what that is and what that means. But really making sure that our lens when we review documents is to see that things are family and youth driven, that we're emphasizing home and community-based services versus residential or more restrictive services whenever possible and appropriate. We're looking for things to be equitable, culturally humble and responsive, trauma responsive, looking for data, all of those things. And we recognize that many, if not most or all, of the recommendations we make in this report require a lot of inter and intra-agency cooperation and collaboration. And it's much easier for us to sit here and say that and put it in a report than it is to do it, especially when everyone has all of the competing things on their plate. And so we recognize that there's a lot of things that we say that are much easier said than done. But we wanted to at least get things on paper and get it to a place where people that can then respond and react. So you already heard some limitations. I'm going to say them again, right? Because I think that this is really important. When we've spoken to a few different groups, I think we make people anxious a little bit with this report, because we're pointing out both areas of strength and some areas that could be improved. And it's really natural and appropriate for people to feel a little defensive. And so, again, this is a point in time. We didn't review everything. We may have missed things. It is not a strategic plan. This is not OHA coming and saying, this is what we're going to do. They very intentionally partnered with us as external folks to look at your system from an external viewpoint. And there are strengths that come with that. And there are things that and limitations that we can't, we don't know your system the way you do. We don't know all the parts. And so there are things that you all need to bring to this as you look at the report and as you hear the recommendations to strengthen it and make it more practical and useful. Again, this is our opinion. The primary audience is OHA and sister agencies. So while we hope it's helpful and relevant to folks at the local level, to families, it was not written for that audience. It is a little more technical because that's who our audience is. And then I just want to take the time to sort of just really acknowledge that we did not address the specific strengths and challenges in financing related to the services accessed by tribal communities in Oregon. So we recognize that as a complex government-to-government relationship. It's important. Health disparities exist across those communities, across the entire state, across this country. And while we think that American Indian, Alaska Native children, youth, and families will benefit from some of these recommendations, we feel like they deserve their own analysis that leverages their input and recommendations, so that we are not explicitly addressing that. Okay. Stop me if you have questions about anything. Otherwise, I'm going to keep going. All right, lots and lots of strengths. And this isn't us just playing lip service. We said this to ourselves when no one from Oregon was present. We wrote it. We've really talked about this to others. You all have done so much good work in Oregon at the state and the local and regional levels to really focus on kids' behavioral health services. Most of your policies and rules are incredibly clear, and you lead with values in so much of what you do in a way that we frankly don't see across the country. Some of your written materials are some of the best we have seen, and are really impressive in how you anchor them all in your values. So I don't want to brush that off, because it is so important, because you've got to start from there. You all know that you're national leaders in expanding access to Medicaid and those authorities, and you clearly prioritize local and regional voice, which is very, very important. And as I said, you continue to make improvements. So we know that OHA was hiring additional staff, already starting to implement strategies, and concurred with a lot of the strategies and said, yeah, we know we're actually already on top of that. So again, that mindset is really helpful. With all of that in mind, here are the things that we saw kind of across. Again, Medicaid lens document review. From our perspective, it seemed that the CCOs had significant latitude in developing their provider networks, establishing their care pathways, how kids and families move through systems, and determine reimbursement rates and billing codes, which can result in an imbalance in the system where there's potentially inconsistent access to services and supports, and families may experience a lack of transparency. That doesn't mean every time in every instance, but we didn't see that consistently there was transparent, equitable pathways, billing codes, and things like that. We found that there are some structures and approaches that need further customization, so that you can address the cultural and linguistic needs of various populations served by OHP, and an importance of elevating the needs of individuals who are Black, Indigenous, and people of color, so that they're not marginalized. And we found there were a lot of areas in data sets in particular where some excellent data was being collected, but there was no ability to disaggregate by various demographic factors in particular, which is going to hinder your ability to find out what's really happening and whether people are getting equitable access and care. And we found that we felt that you would benefit from some more consistent standards across regions and CCOs, particularly related to EPSDT, and identifying opportunities to better delineate services, requirements, performance measures for kids with behavioral health needs. Across all the different recommendations, these are kind of the themes that emerged, right? There were themes related to service access, eligibility, service array. That includes workforce issues and capacity and how that impacts the availability of services. Contracting language, structures, and accountability related to also oversight and performance measurement, quality standards. And then this push and pull, this tension between standardization versus regionalization and customization by CCO, which is a natural tension. It's a tension that exists pretty much everywhere across the country, but yours is particularly strong because of the CCO structure and the way you look to regions and counties. That tension exists. And this is a quote from inside the report, but it's kind of embedded deep in the report. And so we wanted to pull it out here, that a core system of care value, as you all know, is a clear locus of accountability across services and outcomes with coordination across providers, settings, and domains. What we found was that across Oregon, there is a fragmentation, bifurcation of responsibilities, with everyone and no one being accountable for providing high quality, timely, responsive, and effective services and supports. Again, that doesn't mean across every single service, but we saw this repeated frequently, where people weren't sure who's responsible for what. And everybody has a piece of it, so nobody has ownership. Particularly related to kids' behavioral health services that are Medicaid reimbursable, right? So the report makes 47 recommendations. Again, these are our recommendations. It's not to say that OHA is definitely doing, 1 or 47, right? And you can see the kind of categories, how we themed them, and where they're the most recommendations. Sometimes there's a lot of recommendations because workforce, it's complicated, right? Metrics and quality measurement, we only have 3 recommendations, but we have a lot of recommendations sort of related to quality and measurement sprinkled throughout the report as well. So having more recommendations doesn't necessarily mean that that's an area where people are performing better or worse. It just is what we found. So I'm going to give you a couple of the recommendations, and then we can open it up for conversation. I have in the slide deck, which you may already have, but I'll send again. In this slide deck, I have all of the findings, recommendations from the report, so we can skip to any of those. If you want to talk about one of those, I'll go back to that summary slide. But just to talk you through a couple of them. So early periodic screening, diagnosis, and treatment, EPSDT, as you all are rolling out, continue to roll out full EPSDT implementation across the state. One of the things that we found was there was no list of services, and it was unclear how much variability exists across CCOs and how somebody could request services. So we recognize that you all have worked very hard to move away from the prioritized list of services and to make EPSDT a reality, and to make sure that children and families have access to what they need when it's medically necessary and appropriate. And we found that it's really hard to know what's covered and what's not covered because there's no list anywhere. And so our recommendation is to create a list of those services as a guide, as a minimum, so not a ceiling, not a cap, but a minimum, a floor, and then support families, CCOs, providers to understand how to request services under EPSDT if something is not kind of consistently and uniformly available. Another example of a finding was around child welfare and juvenile justice. Again, this wasn't the primary focus, but where it touched behavioral health, we tried to pull it in and address it. And this is not something that's unique to Oregon, but we had concerns about continuity of care and challenges that children and families may experience in accessing services that might lead to things like the temporary lodging or other unintended outcomes. And particularly, we were worried about when children move CCOs. And they move to a different jurisdiction, and suddenly they're covered by a different CCO, and that coverage might be different, and there's different providers paneled with those different CCOs. And so one example of a recommendation related to this was having the CCOs establish MOUs to support federal financial participation, get Medicaid reimbursement for a children's behavioral health liaison to help support that structure and to help ensure that children involved with child welfare and juvenile justice don't have negative outcomes just because they've moved home, which is the outcome we want for them. We don't want them to lose access to care. And then I just have one more slide of some other example ones related to managed care. I noted this earlier. We found that there were a lot of different pathways to care, and it seemed like inconsistent medical necessity criteria, authorizations, utilization management that comes from, leaning into letting the CCOs manage their own networks. And that's part of what Oregon has contracted with them to do, right? Is to be the experts on their community and work with local partners and do that. But it creates a challenge for families and for at the state level and for other providers navigating that. And when there's a lack of standardized coding across services, it's really hard for OHA to be able to answer any questions about who's using which services, how much are they using, and what are the outcomes associated, because you can't pull those data if you're using different codes for everything. So our recommendation was, in a future contract, require, for some of this at least, consistent medical necessity criteria, even like as a minimum floor, authorization, billing codes, pathways to care, with customization happening across that and on top of that, but a consistent kind of floor for all of that. And then we did find network adequacy standards continue to be strengthened, but for kids mental health providers, it still seemed very generic to us, and at a very high level, and not drilled down to the level that kids and families may need. And then finally, just another example around IABHT, we saw some conflicting medical necessity criteria and requirements for authorizations when we looked at the rules. And so this is an example where we felt like there could be some alignment to make sure that this isn't getting in the way of access. It may be that this has never actually impacted a single child and family, and they've been able to get the care, and this hasn't been a barrier. But when we look at, relatively low hanging fruit, this seemed like one of those, because we could just clean this up for consistency. So the full report is on this site, and I know that it got sent out as well. And like I said, I have all the findings and recommendations here, but I'll go back to this list and I'll stop and first say, Suzanne, Lena, did you want to jump in and add anything?
That was a very thorough overview, Deborah.
Yes, it was.
Okay. Hillary, is there anything that you wanted to emphasize or clarify, organize?
No, I think it would be fascinating, or I think this group would be interested in the co-occurring an IDD relationship. I think there are a lot of folks here who have that overlap. So that would be really an area for you to zip to.
Just don't look at the screen while I scroll.
I know.
Okay, I can go to that. Before I go to that, were there any questions on anything I covered? Okay. So this was one of our, this is one of the findings related to state plan, related to kids with behavioral health and co-occurring IDD service needs. We found that the benefits were pretty well defined and a pretty broad array. When we looked at the C waivers and the K plan, we were a little confused. It doesn't mean that it's not in there, but we found ourselves a little confused to figure out exactly how a child with co-occurring disorders navigates across those mechanisms. We also got a little confused by the various authorities that are CCO carve-outs, but the CCO is required to cover the PRTFs and not the home and community-based services. And so we were trying to figure out how that even works, with the CCOs providing care coordination for the individuals receiving home and community-based services enrolled in their CCO, but not being required to cover those particular home and community-based services. So again, these are sort of point to opportunities. Yeah.
You might, if you would just rewind a little bit, we have a lot of parents here.
Oh, great.
Other community members. And so just, maybe just taking that one back to real basics of inpatient and, our facilities that are residential as opposed to community-based, would just, if you could take it to that level.
So these are mechanisms in Medicaid that allow the state to pay for services to be provided in the home and community instead of going into institutional settings. And so that's what 1915C waivers are, and waivers that they're literally just waiving a provision that's normally required. And so this lets the federal government gives permission to Oregon to pay for these services when normally they wouldn't be eligible to pay for them. And so that's all this waiver really does. And it has defined settings where that's allowed under federal law. And that's, most of those settings have terrible names in federal law, like institutions for mental disease and other kind of really terrible names, but they're defined settings, right? And K-Plan is a similar structure that gives some flexibility to the state to pay for these services. And so it's a really good thing that Oregon has gone ahead and utilized these mechanisms. What we found was there were several of them, and they felt a little overlapping in terms of who could access which services. And we didn't totally understand how, if you have a child who has co-occurring needs, whether that's primarily intellectual and developmental disabilities and a mental health disorder, but other co-occurring needs, how you navigate them and which one you use and which has the right benefits for you. So that's what we were trying to call out here. And then it's not that there isn't a way to do it. We were calling out it's not so clear and transparent and maybe not consistent across the CCOs. And then we were trying to figure out, okay, the CCOs, they are required to provide a certain amount of care coordination, but they're not required to provide coverage for certain other services. That happens in the open card system, the fee-for-service system. So then we were trying to figure out, how does that even work if these families who are entitled to certain services and get approved for certain services are then getting care coordination over here, but services over here? And that's really what we're trying to call out here, is this, what we felt like was a disconnect between that. And then the medical necessity criterion, which is the thing that they're supposed to be judging to say, like, yes, you meet criteria, you have a clinical need for this service, and therefore we'll provide it to you. We didn't see a single one established for the psychiatric residential treatment facility, the PRTF level of care, which is supposed to be a hospital level of care in a non-hospital setting for children under 21 with intensive mental health needs. And so if each CCO is setting its own criteria, and that's the basis for deciding if someone meets criteria in this statewide eligibility for a service, we didn't understand how, if you're living in one part of the state, you could get access, but if you're living in another part, maybe you don't get access. And that not being consistent was a red flag to us. Suzanne, did you want to say anything else about that?
Thank you, Deborah. You did a terrific job taking these kind of very technical terms. Potential action here, I think there are a few different potential action steps. So for parents or stakeholders, I think reflecting on this type of goal could provide an opportunity to say, is it clear if I have a child with a need, or I'm working with a family who has a child with a need, is it clear which pathway I take, which set of services could be available for my child or for a child that I'm supporting? And so that's kind of that first set of the recommendations is the pathway to getting those services. Is it clear? Do people know how to do it in such a way to be able to access it? And then the second one has a lot of impact for the state. The state is committed to the federal government to ensure that a set of services is going to be available for all Medicaid beneficiaries. And so with the implementation within the CCO structure, allowing CCOs to customize to such a degree that there is variation from a statewide perspective, the state needs to be able to say that variation is still consistent with what we've said we're going to do. And the documents don't seem to shed light on if that's really happening or not. And so that's an important second call out for this set of recommendations and how to move it forward.
So see, we tried to really think about how would a family navigate, and how would a provider who's partnering with a family know who to call, what to do, how to access things. So throughout most of these things, it may be that there's an answer. It's just that we didn't see it really clear and consistent. And so that's one of our kind of overarching recommendations. We also noted that nationally, there's tremendous opportunity to improve how we provide diagnosis and treatment to children and youth with co-occurring behavioral health and intellectual and developmental disabilities. And so we made a number of recommendations related to this that are not necessarily specific to Oregon, but they're ones that we think probably every state can do better around. So we included them. In particular, that nationally we see, excuse me, a lack of training and expertise among behavioral health providers in their capacity to engage, assess, treat youth with co-occurring IDD and behavioral health needs, or know how to adapt treatment appropriately for that population, and that we tend to see a lack of genetic testing that would support diagnostic evaluation to then hone in on most effective treatment and services. And so our recommendations in this area, I feel like there's a number of them, but, really have some specific training and coaching for providers around the specific needs of behavioral health needs of youth who may have IDD. Look at population level data on who's using services and what their outcomes are across all of these C waivers, K plan, all of these services to and across each CCO for this population to get a better handle on who's accessing which services and what are their outcomes, what is their trajectory, are they able to stay successfully in their home and in their community, or are we seeing the services not being effective, or people aren't even accessing what could be effective. We highlighted that we feel like there's more need to solicit meaningful input from families and youth with this co-occurring needs. And throughout the report, we kind of call this out. I think Oregon does a decent job of trying to make sure that individuals with lived experience are represented in things. But in a number of places, we didn't see that necessarily youth were represented or families who are caregivers of children and youth. So we felt like it might skew toward adult consumers of services, which is important, but we know kids are not small adults and their experience and systems are different. And so making sure that those voices are meaningfully represented. And then we wanted to encourage folks to push out guidance to families, to CCOs, to others on importance of genetic testing when there's a suspected intellectual or developmental disability, because under EPSDT, this benefit that exists, genetic testing might be covered beyond what is detailed in the prioritized list, but because the prioritized list gets trumped by EPSDT now, right? If the services are medically necessary and appropriate, but because the prioritized list still exists and is referenced, and it has a more narrow definition of when genetic testing is appropriate. So being able to draw folks up to maybe the American College of Medical Genetics and Genomics with their recommendations for testing and linking that to help identify medically necessary and appropriate services. And then another comment was just making sure that there are efforts underway to expand those K plan services to provide better access to individuals with behavioral health needs. And our concern is that that is not done in a way that sets up a parallel system to the existing systems to support kids with intellectual and developmental disabilities through the K plan. We know that you can't suddenly knock on somebody's door and be like, hey, now serve all these kids too. But we also think it's not in anyone's best interest to set up a parallel system. So figuring out the way to align and integrate those pathways so that you're expanding capacity and but working within a structure that folks have already set up, it seems to be relatively successful. Questions about that?
There's a comment in the chat. Whenever I see a push for genetic testing for IDD community, I worry about eugenics. Do you have a response to that?
Yeah, I know. I feel that. I had a great conversation though with a excuse me, a neuropsychologist from Kennedy Krieger Institute at Hopkins not long ago, and I live in Baltimore, so those are our people, and we were talking about the ways that kids with a suspected IDD need might be identified, and the ways that treatment can be improved to support them if you do that testing, and that so often kids are sort of just pigeonholed into, oh, it's this behavioral issue, where if they could identify the specific, that there was fetal alcohol syndrome, that there was other kinds of disorders, particularly the kids involved with child welfare, who maybe we don't have a full history on, and they're presenting with certain behaviors, the folks, the neuropsychologists that I spoke to really talked about the way that they can customize treatment and be so much more effective and successful in partnership with the family when they have that testing. So definitely not for everybody, and certainly health privacy is really important. But thinking about it for a kid who has a behavioral need where you're not experiencing successes in that treatment.
Jenny?
Yeah, I just want to say that my son actually was on the neurobehavioral unit at Kennedy Krieger Institute, where he got PTSD from ABA therapy. So it always makes me nervous when I hear Kennedy Krieger brought up, because they're doing some really harmful things on their neurobehavioral unit to intellectually and developmentally disabled children.
I'm really sorry that you had that experience. And I know ABA in particular is something that families I've spoken to feel really strongly either pro or con, and it's rare to find a family that is neutral. It's rare to find a clinician that's neutral on it. I am not a clinician. I have an MSW, but I'm not a clinician, so not weighing in on that in particular. But I'm sorry for your experience, and I hope, yeah, very sorry. Suzanne, I feel like you want to jump in.
Yeah, we would welcome any resources or anything that you all would recommend in this area. This is a particular push point across the country between medical professionals and those who have experienced the use of genetic testing in a way that was more than just trying to understand a diagnosis. And so this feels like one of a few different issues in our report that are really weighty, and that we have to be very thoughtful in how we continue to approach. So I appreciate, even though that this is uncomfortable, I really appreciate the space to be able to say it and try to continue the dialogue on it. So again, I certainly don't want to ask anybody to go out and take a lot of time to send us things. But if you're aware of anything in this space, please do share it with us. And so we would appreciate that. So thank you all.
Yeah.
Thank you to all of you. We have about 5 more minutes. So I'd like Roxy, feel free to comment.
Thank you. I'm feeling the very strong need to talk about that eugenics and the genetic testing, because as a personal experience with my son who I'm a psychologist, I'm a neurodevelopmental psychologist. I had to have my kid go through this because I obviously can't diagnose him myself. We went with a recommended provider with a pediatric clinic and did the testing. And at the debriefing right afterwards, they had said, for one condition that they're kind of curious about, which I know personally definitely was not my son, but also they said for family planning purposes, we're recommending genetic testing. And I said, hold on, let me get this right. Would this be a blood draw? And I mean, this is a point I didn't really know, but she said, yes, this would be a blood draw for him. And I said, so my child who has been medically traumatized, you want him to go through a blood draw to see if, for our own family planning purposes, and potentially if he wants kids one day? And the answer was yes. And I blew up with the medical director. I was just like, this is the way that people are having conversations about this, whether it's for testing to help with diagnostic clarity for treatment plans, or in my shock and disturbance for family planning, this was a highly recommended clinic, and this is how they were approaching things. And I was like, because what that said to me is that my son's autism in your eyes is so bad that we should know that in case we risk having another child, or he wants to have a child one day. It's appalling how this happens. And I think there needs to be so much education around that, about how you're talking about things, if it's for a specific reason, but also family planning should be brought up by the family. And I think it should be said in a way of, like, we have specialists that can talk to you about any kind of genetic links, or if you have questions about this, we have a question about this one thing, whatnot. But honestly, it's horrifying how these discussions come up. And if I wasn't in the power position that I am in, or if I spoke a different language, if I was, not somebody that felt represented in the clinic, that would have crushed me and would have brought in so many different flooding of feelings versus just anger. And this is a huge need. So yes, I think genetic testing is important. There's a lot of times that I recommend for really complex kiddos. I think it's called pharmacogenic testing, to kind of talk about, if we're talking about medications, to help that pathway, to not do so much trial and error with the kiddo. But this is such a training need, and the impact of those conversations on families goes so deep and can really, really mess up relations with people, or how they're feeling, their own guilt, things like that. It was very hard for us.
Roxy, thank you so much for sharing that. Obviously, this is an area of more discussion and need for us to come back and circle to, perhaps in another space where we can have some more thoughtful and intentional conversations about that, and then carry that message forward. So thank you all for sharing. Yukon, I want to give you all the final word to just add anything else and kind of wrap that up, and then I will share one more thing before we move on.
No, I just want to thank you for sharing your experiences. I mean, this is why families need to be at every table. This is so helpful and impactful. And I'm going to go back to Hillary and Chelsea and see if maybe we make a couple of word adjustments too, to make sure our recommendations aren't taken out of context. And so I think even just clarifying the importance of genetic testing when requested by families, or things like that, because our real goal is to help make things more transparent and accessible. And so figuring out how to support that mechanism, and we never want to put something that would cause harm or damage relationships. And so this is really helpful and impactful. And if you have materials to send, like Suzanne said, absolutely send them to us, send them to Hillary. She's an amazing champion, and she will both take it in and read it all herself and send it along to us. And so we don't want to put the burden on you to do the work, but if you have things that you'd like to share with us, we would appreciate that very much.
Yes, and there was a note in the chat as well about other ways to send that information. So anyone is always welcome to email myself or Tamara or Hillary with any thoughts or additional conversation, and we can certainly bring them back to the group as well. So thank you so much for the presentation and the thoughtful work that you all have done, and kind of doing that analysis for us. And so we look forward to taking that forward.
Thank you so much. Thanks for having us and for all you do.
Thanks, absolutely. Well, just to wrap up, everybody, I wanted to just, again, as we move into May and Children's Mental Health Acceptance Month, be thinking about, how you can kind of reimagine what acceptance is for children with mental health needs. The Kid Governor is got a campaign to reduce mental health stigma for children, and it's really nice to see her do her work. And as we move into May, it's a time dedicated to teaching individuals and communities about the importance of mental health for our children and youth, and advocating to improve supports and services, celebrating the work that's been done already on behalf of young people who experience mental health challenges. And then in May, we're going to promote acceptance, and we're going to celebrate hope, strength, and the resilience of youth and families. And so if you have a green ribbon and you want to wear that to show support and tell people about what your green ribbon means and why you're wearing it, that would be awesome. Remember, we have the two events that OFSN is hosting there in Salem on the 9th and the 11th, and that information and registration is on their website. So we hope you'll join us, and just thank you all for the work that you do, and we look forward to seeing you in May. Take care, everybody.
Bye. Thank you.
Bye.